Thank you for joining us this evening, and welcome to the Medical College of Wisconsin Community Town Hall. And I want to sincerely thank you and appreciate your interest and engagement tonight. I'm Dr. John Raymond, the President and CEO of the Medical College of Wisconsin, and I'm pleased to be hosting another Community Town Hall, our first since May. If I could go to the next slide, please. I'm joined today by two guests, Dr. Laura Cassidy, Professor and Director of the Division of Epidemiology of the Institute for Health and Equity at the Medical College of Wisconsin, and a special guest, Milwaukee County Executive David Crowley. Now, our goal today is to bring you up-to-date, accurate information about how the COVID-19 pandemic is affecting our communities, and to answer your questions to ensure that you can best take care of yourself, your family, and your community. Dr. Cassidy and I will start with a presentation about COVID-19, and this will include answers to several questions that were submitted ahead of time. Then we'll invite County Executive Crowley to speak with you. Then we'll conduct a brief poll about future webinars, and finally, we'll answer audience questions that will be submitted during the webinar with the remainder of our time. If I go to the next slide, this slide summarizes COVID-19 trends as of today. Starting on the left-hand slide of the side, the R number, which is a measure of contagiousness of coronavirus, is 1.27 in Wisconsin and 1.0 in Milwaukee. Now, we need that number to be less than 1.0 or the pandemic is growing. So that R number of 1.27 in Wisconsin is troubling. The percent positive tests over the last week also is a troubling metric, because it's at 14.9% in Wisconsin and 8.6% in Milwaukee. And these numbers are high because the positivity rate should be less than 5% if we're testing enough people. Now, by comparison, the positivity rate in New York, where the pandemic now is mostly under control, has been under 1% for the last month. On the lower left-hand side of the slide, you can see that over the last week, we've averaged 1,171 new cases of COVID-19 in Wisconsin each day, with an average of about 111 new cases each day here in Milwaukee. So although we're doing better in Milwaukee than the rest of the state, we are beginning to head in the wrong direction. That average number of new daily cases was about 60 a week ago. Now, in the middle of the slide, there's more promising data. The increased number of new cases hasn't yet caused increases in hospitalizations or intensive care unit admissions. And we have adequate hospital rooms available for anyone who needs them, plenty of ICU beds, plenty of ventilators, and our hospitals have enough personal protective equipment to take care of all patients. And the supply chain seems to be stabilized compared to where it was a few months ago. On the far right, you can see that the death rate also has not gone up. It's been stable in Wisconsin now for several months, and it's very slowly decreasing in Milwaukee. Still, we've had 1,210 COVID-19 related deaths in Wisconsin and 420 in Milwaukee, and that's too many. So why is it that the middle and right-hand columns aren't looking as bad as the left-hand column? We think this is largely due to the number of new cases being almost exclusively in younger individuals who are less likely to be as sick as older individuals and may not require hospitalization. Still, they may pass that disease on to older colleagues, family members, and coworkers. So we really need to watch that closely over the next 4 to 6 weeks. If we could go to the next slide, please. This slide compares the 7-day average reproductive numbers since early March for Milwaukee in gold and Wisconsin in blue. And recall that this is a measure of contagiousness, and we want that number to be below 1.0. So starting at the left, you can see we took a troubling turn in mid-June with the reproductive numbers, both in Milwaukee and in Wisconsin, climbing over 1.0 for 40 consecutive days. Now, the Milwaukee mask ordinance went into effect on July 17th, and then a few days later, the 7-day average reproductive number dipped below 1. And the reproductive numbers remained at or below 1 in Milwaukee for the last 6 weeks. Now, Wisconsin also dipped under 1 for a while, but the reproductive number has crept up over 1 for the last 3 weeks, as you can see on the right-hand side of the slide. And so this is a troubling trend. Next slide, please. Now, this next slide shows a graph of what we call the trajectory of COVID-19. And by doing this, we plot new cases for the last 7 days on the vertical axis against the cumulative number of new cases since the beginning of the pandemic on March 12th on the horizontal axis. This plot's presented using logarithmic scales just to emphasize changes in the trajectory. So for this type of plot, a downward movement is good, and it indicates a shrinking or deceleration of the pandemic. Milwaukee is shown in pink and the rest of Wisconsin in light blue. And as you can see, Milwaukee had shown a very clear downward, favorable trend for about 6 weeks. And this coincided almost directly with the initiation of the Milwaukee Mask Ordinance on July 17th. Unfortunately, the rest of Wisconsin hasn't seen such a favorable trend. And this is largely because COVID-19 has spread throughout the state with high activity in nearly every county of the state. And recall that early in the pandemic, the burden of COVID-19 was predominantly in southeastern Wisconsin and mostly here in Milwaukee. It then spread to northeastern Wisconsin and then throughout the state. Now, even though Milwaukee had a favorable trend for quite a while, that trend has stalled for about the last 5 days. And I know that's difficult to appreciate on the graph, but if you look on the right, the 2 arrows with the little circles at the end show you that we're not making any more progress than we were before. And so this bears watching. Next slide, please. Now, on this next slide, I just want to give a basic primer of the 3 types of COVID-19 tests that are available. The best test is a COVID-19 RNA test, and that's taken either by a deep nasal swab or by saliva, spitting into a tube, so to speak. And that's used to diagnose current infections by detecting genetic material from COVID-19 virus. This is the gold standard. It's the best test available, and it's highly sensitive and specific. And what that means is if you have COVID-19, this test is probably going to detect it. If you don't have COVID-19, you're probably not going to have a positive test. So this is a very good test. The problem with this test is that it is labor intensive. The turnaround time sometimes takes days, and there's concern about the reagents or the chemicals needed for the test. That supply chain is very fragile. Now, the second type of test is something that you may have heard about in the last few months called an antigen test. And what this tests for is virus protein, and not the genetic sequence, but the protein either on the inside of the virus or on the virus coat. And this has some real promise. This test is less expensive and can give a quicker turnaround time than the RNA test. And it is highly specific. So if you have a positive test with an antigen test, you're very likely to have COVID-19. It gives you good turnaround, it's inexpensive, but the sensitivity isn't perfect. So we could miss some people that have COVID-19. And then the third and final type of test is a serological test or an antibody test. And those are widely available and were talked about quite a bit in March, April, and May. And this test measures your immune system or your immune reaction to COVID-19 by measuring the antibodies that you would make against COVID-19. Now, this test is less expensive than the RNA tests, but its performance is extremely variable, and it really hasn't come into common usage. So the 2 that you really need to pay attention to are the coronavirus RNA test and the antigen test, because those can diagnose an active infection. If we could go to the next slide, please. These are some things to think about as you return to work, or you're thinking about workplace safety or safety in the school setting. So as we said, the RT-PCR, this RNA test for COVID-19, really is the best test. It's the gold standard. On the other hand, the results are only good for the day that the employee was tested. So if you have a negative test, it's possible that you could have COVID-19, but you're in an asymptomatic phase, or a phase where you're not showing symptoms yet, but you could show those a day or 2 down the road. So it's expensive, it's cumbersome, and it's really only good for a day. Now, temperature checks, many employers are using temperature checks. These are good, but depending on how many people in your community have no symptoms, and we think about half of the people that have COVID-19 have no symptoms or minor symptoms, the temperature test is really low sensitivity. Also, if you're going to a place of employment or business that has a lot of traffic, it may be cumbersome, it may be difficult to screen lots and lots of people. And in fact, the person doing the screening might be exposed to a lot of people, and so there might be some risk for them. On the other hand, employers are using temperature screening to show a commitment to safety for their employees and their customers, but this is really not a very sensitive screen. Now at MCW, we use a daily symptom self-screening tool that people use before they come to work, and includes the 14 most common symptoms of COVID-19. And you can either log into that site on the internet or use a mobile phone application. Again, serological tests or these antibody tests really aren't particularly useful right now. At the beginning of the pandemic, we hoped that if you had antibodies, you could get something called an immunity certificate that would say that you're safe to return to work. But we really don't have confidence in that test up to this point. So there's limited value for return to work. Next slide, please. Now this next slide is a concept slide. And really this has to do with our thinking about how COVID-19 spreads. So if you want to slow the spread of this virus, which you can get from inhaling the virus, either in aerosols or in large respiratory droplets that people make when they cough, sneeze, or talk, or by touching a surface that's been exposed to COVID-19. If you think about it, the number of exposures you have, or the more people you interact with, the higher your risk of being exposed to COVID-19. The closer you are to a person, the more likely you are to get COVID-19 if they have the disease. And the other thing people haven't thought about much is the intensity and the duration of exposures. And what I mean by intensity is if someone is shouting, singing, speaking loudly, coughing, or sneezing, they're going to expel more respiratory droplets. So that intensity of exposure is going to be higher than if somebody is sitting quietly in your 6-foot space bubble. And then another thing people haven't really thought about is the duration of exposures. So if you're sitting in a crowded bar or a church where you're at a service where you're there for more than an hour, that's a pretty significant length of time for exposure. So when you think about reducing your risk, think in terms of these 4 variables. So for the number of exposures, if you avoid crowds, if you stay at home or you work from home, you're going to reduce your exposure to COVID-19. If you maintain that 6-foot physical distance, reduce the proximity, you'll reduce your exposure to COVID-19. If you avoid singing, shouting, if you limit indoor activities, you wear a face covering, you wash your hands, you're going to reduce that intensity of exposure. And if you limit your time of exposure with people, then you'll reduce your risk of getting COVID-19. And those are 4 simple variables that you should think about in terms of your risk. Next slide, please. This is just an information slide, just so that everybody understands a little bit more about COVID-19. As I mentioned earlier, it is estimated that half of COVID-19 transmissions are from people with no symptoms or mild symptoms. Now, this is really important. If you think about the rise in cases that we're having now, and that most of those are in young people who are less likely to have symptoms, you could easily imagine a situation in which a young person feels fine, but they have COVID-19 and they pass that on to a loved one in their family who may be at increased risk, somebody that's obese, they have cardiac disease, or they're over the age of 60. So we are pleased now that in our state we have quite a bit of testing. And so that testing does result in earlier detection of people either before they get symptoms or if they have mild symptoms. And this, in theory, at least allows us for earlier quarantine and isolation, and that can prevent the spread. So that's a public health tool. And earlier detection by testing means better triage and treatment. And we know a whole lot more about how to treat COVID-19 now than we did earlier in the pandemic. And we continue to improve our knowledge every day. Now, testing also allows for contact tracing, and earlier interventions mean tighter testing cycles for people that are exposed to an infected individual. So we can more rapidly identify people that are exposed, get them tested, and get them back to work and to resume their normal life. And testing also allows earlier detection of outbreaks in neighborhoods, workplaces, and in congregate living situations like nursing homes and prisons. These are some things that County Executive Crowley has been working very closely with our public health officials in Milwaukee County to try to tighten that cycle and increase the availability of testing. So now I'd like to turn the presentation over to Dr. Laura Cassidy.
Next slide, please. Thank you, Dr. Raymond. When we first were learning about COVID-19, we were under the impression that it was primarily a respiratory disease. And as time has gone on, we've learned a lot more about it. And I think we're all pretty familiar with the basic symptoms of COVID-19, but there are some long-lasting side effects that we're learning about. It's a multi-system virus, and people who have gotten through the acute stage have reported long-term effects such as a persistent loss of sense of taste and smell, problems with their memory and thinking clearly, lung scarring, kidney or liver failure, heart failure, stroke. There's people who've had to have digits or limbs amputated, skin lesions, fatigue and muscle aches, depression, and difficulty walking. So we are really new to this virus. We've only have about 8 months of experience, and so we're still learning about it. So when we think of it in terms of flu and other viruses, the consequences and long-term consequences can be much more severe. Next slide, please. And we're also learning about whether or not reinfections are possible. And it's very uncommon, but they believe it is possible. And we've also learned that there's evidence, as Dr. Raymond was talking about, with the antibodies, that you can get antibodies after the infection, but there's some people who don't actually develop detectable antibodies, and also they can drop significantly within a few months and be hard to detect. So you may have had it and not known it, and you get the antibody test, it could be negative. But the good news is we do believe that there's T-cell immunity that can be used to help with vaccines and with longer term immunity. Next slide, please. And the CDC has put out guidances for isolation when you're diagnosed with COVID, and they've recently made some changes to those recommendations. So basically, if you're tested for COVID-19 and it's positive, you're supposed to self-isolate for 10 days after the positive test and make sure you're symptom-free for 24 hours. It used to be 72 hours. Have an improvement in your respiratory symptoms, but also in all your other symptoms. Because we've learned about, there's so many other symptoms besides respiratory symptoms, such as diarrhea, headache, muscle ache, and others. And if you have a more serious case and more serious symptoms, you may have to isolate for longer. Next slide, please. We took a closer look at some of the data in Milwaukee County. There's been a lot in the news about the health disparities associated with COVID-19 and how it disproportionately affects certain communities. And there's a health disparity in who might be at risk for this. We know that with age, the mortality and hospitalization rates increase at a linear rate. As you get older, your risk increases. You're just not able to fight off the virus as much, and you might have comorbidities. There's not a whole lot of difference in gender in rates of testing positive, hospitalization, or death. And right now, the rates are very high among our younger population, the 20 to 39-year-olds. So in order to account for population size, we looked at the number of cases per 1,000 residents. So instead of just reporting the total numbers, we looked at it in reference to what the population size is to get a better handle on how are people faring in these different racial and ethnic categories, excuse me. And so when we look at the cases, Those are people who have tested positive. And we only know that they tested positive if they get a test. So keep that in mind. We don't have widespread testing that's generalizable to all populations. So the Latinx population has the highest rate of positive cases per 1,000 residents. It's almost 55 people per 1,000 residents. And that's followed by our Black American community and African American community, 26 positive per 1,000 residents, and followed by Alaskan Indian, American Indian, Alaskan Native, and Asian. So these are people who have gone in and gotten a COVID test. So people go for different reasons. They might go because they have symptoms. They might go because they have to go back to work. They think they've been exposed. So we call that a selection bias. So there could be some bias in these numbers. Now, when you look at hospitalization rates, the hospitalization rate is 14.3 per 1,000 Black residents in our community. So the hospitalization rate is highest in our Black communities. And so this is sort of counterintuitive, because if there's more Latinx population who are positive, but they actually have the lowest hospitalization rate and the lowest death rate, what does this all mean? Well, it's a complicated issue. Part of it could be that our Latinx population may be a little younger. Those who are getting tested may be a little younger. There was also a big push for testing on the South Side, and they had a lot of campaigns. They did a lot of testing. There could be some cultural components with certain people who don't want to get tested, don't have access to testing, or they wait until they're really sick to get tested. So it could be that they're not getting tested early enough in the process, or with less severe disease. But with hospitalization and death, there's not really a selection bias. If you need to be hospitalized, you need to be hospitalized. And unfortunately, the death rates are what they are. So this is something that's alarming, and we need to think about, why are these rates the highest in our Black population? Is it because they have more comorbidities? Is it because of the age of the population? With deaths, I think it's both the Black and white population are skewed toward an older age group. So it's the actual composition of the population who's getting tested. Next slide, please. And we need to do more analyses looking at that. So whenever we talk about a health outcome and how people are doing, we really need to talk about determinants of health. And we know that the clinical care we provide, the healthcare we provide, accounts for 10% of the outcomes. The rest is dictated by who we are, how we live. There's some genetic predispositions in biology. Some people have, their genetic makeup just makes them more predisposed for different diseases. Sickle cell is an example, or other diseases. And there's also our health behaviors. Smoking, if we eat healthy, if we exercise, how much stress we're under. There's social and economic factors. Those have a big influence on our health. And our physical environment, where we live, dictates how we live. And so when we're looking at COVID-19, we need to think about these things. People's mental health affects their health outcomes. Income and job security, housing, are they living in crowded houses where the disease is passed more easily? Is it a crowded community where it's passed more easily? Are they homeless? Do they not have access to homeless? Do they have access to nearby health centers and hospitals? Are they in a food desert where they don't get access to healthy food? Environmental safety, access to green space to get outside and play. And social isolation can have a big impact on how we are, how we do our social support network. So when we're looking at COVID-19 and health outcomes, we really need to factor these things in. And there's also been a lot of research on adverse childhood experiences when children are exposed to a lot of stress growing up, whether it's within the home and family, within the schools, the community, if their parents go through a divorce, or they're maltreated or malnourished, if a family member goes off to war, a family member dies, if there's violence in their neighborhood, if they live in a community that isn't healthy, where they don't have access to healthy food, this stresses children, and studies have shown that they're at greater risk of chronic disease when they get older or throughout their lives. So they're greater at risk of diabetes, heart disease, stroke, cancer, mental illness, and obesity. Well, these are all also risk factors for COVID-19. So when we talk about equity, we have to think about how we can improve these situations, improve the health of our communities, because we're all part of the same community. And what happens in one community affects all of us, and we care about each other. Next slide, please. And then to weave this into the risk of getting COVID-19, our social determinants and our determinants of health are also interwoven with our risk of getting COVID-19. So again, our income level and age and education level, we know older people are at higher risk. It increases with age or higher risk of a worse outcome. Younger people seem to be at a bigger risk of getting it right now, but that's a behavioral factor. Our workplace interactions. Not everybody has the privilege of being able to work at home. Not everybody can do that. We have our frontline workers, we have our healthcare workers, our transportation, people who work in stores, mail delivery, people working in manufacturing plants. They have to. There's people whose jobs are interacting with other people, and they have to do it in person. So right there, they're at higher risk. They're interacting with other individuals, so they have to choose between their livelihood and potential exposure. That's not easy. And then our, pre-existing health conditions and our lifestyle. So, people who have chronic diseases are at higher risk of COVID-19. And smoking, that damages your lungs, vaping, those things can all put you at a worse disposition if you do get it. So all these things integrate into the risk of getting COVID-19, and it's also entwined with our overall health. Next slide, please. And when we're talking about health, determinants of health, and health outcomes, there's other things we can do. And there's been some talk and some buzz about the flu vaccine increasing the risk of COVID-19. Well, that's not true. No. The flu shot does not increase the risk of COVID-19. The flu shot does not prevent COVID-19. They're both respiratory viruses primarily, but they're different viruses. So the flu vaccine protects you against different strains of influenza, and the coronavirus is not the same strain of influenza. So it won't protect you against it, but they are working to develop a vaccine against COVID-19. But what the flu shot does is it keeps us from getting the flu. And if we're healthier, we're more able to fight off COVID-19 if we're exposed to it. Again, it's at baseline health. It's a simple thing to do. You don't get the flu, that's a good thing. You're healthier if you do get exposed to COVID-19. And there was a recent study that looked at 90,000 people in Brazil. And what they found was those who reported there were fewer deaths from COVID-19 by those who had received the flu shot. And there was another study in Canada that showed the same results. And also, if you do end up getting the flu and you get sick, you're going to be weaker. And then if you get exposed to COVID-19, you're going to have a little more trouble fighting it. And importantly also, if the flu vaccine prevents you from getting the flu, then it prevents hospitalizations. So it reduces the burden on the healthcare system. So if we have a spike in the flu and a spike at COVID at the same time, one of the problems is, it may be hard to tell the difference between the two. And the other, if they both get really sick at the same time, we will overwhelm and overburden our hospital system. And that's always a concern. But going into flu season, it's especially a concern. And so currently, only about 40% of people in Wisconsin get a flu vaccine. So that's something we can do. That's something everybody can go get a vaccine. If we can get those rates up and decrease the flu, we're healthier, we're able to fight it. That, along with wearing masks, washing your hands, social distancing, these are things in our control to do and, that are recommended by science and the health professionals. Thank you. Next slide. And now I'd like to introduce David Crowley, the County Executive for Milwaukee County. Thank you.
Thank you, Medical College of Wisconsin. Thank you, Dr. Raymond. Thank you, Dr. Cassidy, as well. I want to say thank you all for joining us, and want to say thank you for remembering the 3 W's, which is watch your distance, wash your hands, and wear a mask. Since day one of my administration, I've really emphasized the importance of following the guidance of public experts such as Dr. Raymond and Dr. Cassidy. I'd like to commend the work that the Medical College of Wisconsin has done in elevating and amplifying actionable and public health-based guidance for individuals and organizations about how we can best respond to the COVID-19 pandemic. In addition to that, I would like to also thank the 11 local public health officers for their tireless work to protect the health of our communities. I'm proud of the work that we have done here in Milwaukee County to support the Unified Emergency Operations Center, or the UEOC, to create a shared response to the pandemic just all across the county and across all of our communities. And as we are all aware, the COVID-19 pandemic has exposed other significant challenges we face in Milwaukee, including the pandemic of structural racism. For many reasons, the burden of COVID-19 has hit Black and Brown communities especially hard. My vision for Milwaukee County is that by achieving racial equity, we can be the healthiest county in Wisconsin. And though we've ranked second to last as the healthiest counties in Wisconsin, we're putting a full force of our county's effort towards advancing this vision. First, we're going to create intentional inclusion. We want to make sure that leaders and managers across the county represent the full diversity of our community. Second, we want to bridge the gap by transforming how we provide services to meet the needs of our county residents, but also focusing on resolving our community's unacceptable health disparities, including the 14-year life expectancy gap between the average Black and white members of our community. And third, we're going to invest in equity by putting our money where our mouth is and using a racial equity budgeting tool to prioritize how we spend our scarce resources at the county. We're also doing everything that we can to advocate for direct and flexible funding so we have the resources needed to meet the growing needs for mental health, housing, and other critical needs that have grown even more since the start of this pandemic. But I'm also pleased to see partnerships happening here in Milwaukee County, such as the Medical College of Wisconsin and the Greater Milwaukee Foundation, who's committed to advancing racial and health equity. Just recently, they've announced their collaboration on 5 priority areas of investment. First one is increasing the availability of safe and affordable housing, improving education outcomes by investing in early childhood education, increasing access to health and wellness facilities and food options, and building positive social and business relationships and supporting small businesses and entrepreneurs. We're looking forward to partnering with them to advance the health and well-being of our entire community. And again, I really appreciate everybody being here and look forward to all of the questions you may have.
Thanks, County Executive Crowley. Eric, are we going to do the poll now?
That's right. I have polls ready for our audience to answer, and the first one's coming up. I'll go ahead and read it, and when we get about 50%, we'll share the results. So this first poll question for you, everybody, is: would you be interested in a webinar series featuring scientists and doctors discussing research in health and science fields? Yes or no? And we've got about 5% voted, so I know you can do a lot better than that. We're up to 12% and climbing. And I'll give you a sneak preview, everybody. It's kind of lopsided at this point in terms of the stats. 39% voted. There's 50%. I'm going to close it in 5, 4, 3, 2, and 1. And here are your results. 94% of your audience would be interested in that webinar series. So with that in mind, second question, if you answered yes, you 94%, please select which of these 5 would be the most interesting for you. So cardiovascular health and disease, cancer prevention and novel treatments, health equity, infectious disease, including viruses, or mental health. And this is a little more even spread. We've got about 13% voted, closing in on 20%, 25%, 30%, here we go, 40%. There's our magic 50% number, and I'm going to close it in 5, 4, 3, 2, and 1. And here's your results. Looks like health equity narrowly edged out infectious disease and mental health. And the first 2 options were in the single digits, but high. So pretty broad spectrum there on those. Any comments from the panel? All right.
Well, we thank everybody for their input, and we'll arrange some more webinars.
And health
That's
equity
right.
is cost cutting in all of those topics. That's my pitch.
I was going to say the same thing. I'm glad so many people are invested in doing a lot more around health equity.
Well, we have a ton of questions from both the audience and that were also submitted in advance. And so some of those questions that were submitted in advance were addressed by your remarks, the three of you. But I'm going to start with the first audience questions and work our way through our live audience here. And the first question came from Sue, and this is for Dr. Raymond. How is the antigen test performed?
Yeah, thank you. Great question. Antigen test is done in a very similar way that they do the PCR test or the RNA test. You collect either saliva or a nasal swab. And the advantage to the antibody test, or I'm sorry, the antigen test, is you don't need the deep nasal swab. It's more like a little Q-tip that you can stick into the front of the nose. And at some of the kits, actually, you take the swab and you put it in a test tube, and you get the result read out in about 10 minutes.
Very good. Next question is from Joan. This is for both doctors. Do we know whether the spread is mainly aerosol? Put another way, is there still a substantial risk of infection from surface touching?
Laura, do you want to answer the question?
Sure. Yeah. The primary mode of transmission is by respiratory droplets in the air being passed from one person to another, coming out the nose and mouth and going in the eyes, nose and mouth. But there is still a risk if somebody sneezes or coughs on a surface and the virus is on the surface and you touch that surface, then touch your face. And it's been shown that it can survive. It can live probably up to 2 days on cardboard and or a day on cardboard and a couple days on stainless steel. So, you know, keep sanitizing and washing your hands.
Very good. The next question is from Heba, and this is for both doctors with maybe some County Exec Crowley perspective here as well on vaccine perceptions. Hello, I want to know what's going on with everyone sending warnings about the new coronavirus vaccine. Is there really a vaccine? And if so, what is it made of and how does it protect from the coronavirus? Since we know that the coronavirus is an RNA virus and it keeps changing. So would this vaccine be like the flu vaccine, something that we have to get every year?
I'll start, and there's a lot in there. It's several very sophisticated questions. First of all, this is an RNA virus, but it doesn't mutate as quickly as the flu viruses do. So we'll start there. But the immunity that you are going to get either from an infection or from some of these vaccines probably isn't going to last your lifetime. So 2 of the 3 vaccines that are being tested in the US right now need a second dose a month late after your first dose. And it may be that we need to get an annual vaccine for the COVID-19, but we're not 100% sure about that. Now, in terms of safety, one study, and this is one that was being done by AstraZeneca, was held last week for 4 days because one patient enrolled in the study had a neurological problem. They had inflammation of their spinal cord. It's called transverse myelitis. It's a very rare condition, not necessarily associated with the vaccine. So they put the trial on hold for a few days to make sure that nobody else was having a similar problem and to make sure that the person who had the problem was getting good care. They started that back up again. And, you know, obviously this COVID-19 is a deadly disease. We're trying to expedite the development of the vaccine. Now, how do you make a vaccine? The way that the companies in the US are doing it either are to inject the RNA from the virus that's synthetic, or to inject a piece of a protein from the virus, again, synthetic, that they make in a laboratory. And then your body recognizes those and creates antibodies or activates what Dr. Cassidy mentioned, T cells, that rev up your immune system so that you can recognize the virus. So it's likely that we'll have a moderately effective vaccine, maybe more than one, and I would say available on a limited scale before the end of this calendar year. Probably it won't be available to the general public, because if you think about it, you're gonna have to make hundreds of millions of doses to be able to immunize everybody in the US. And there just isn't that manufacturing capacity to scale up that quickly. I plan to get the vaccine when it's available. It'll probably be made available to frontline healthcare workers and first responders first. And I'd be happy to hear what Dr. Cassidy thinks about the vaccines.
Yeah, I don't really think I have anything to add. That was pretty comprehensive.
Would you take the vaccine if you felt that it had gone through the usual safety procedures?
Absolutely. I would definitely get the vaccine because I don't want to get the disease. And I want to protect the people around me. I don't want to spread it either.
And just so everyone knows, the 9 major vaccine manufacturers in Europe and the US have signed a pledge to not distribute a vaccine that they don't believe is safe. So we at least have that. On the other hand, we have this enormous pressure to do something with the vaccine so that we can counteract the effects of this disease, not just on our health and well-being, but on our economy as well.
Which I would say is one of the things about that is it's promising when you have drug makers saying that we're going to do everything that we can to make sure that it's safe for this community. And as a community leader and as a politician, it's important that we're doing everything that we can to mitigate this virus, and that is getting vaccinated. And so we're going to continue to encourage people not only to get a flu shot, but when it is safe and we have a vaccination for COVID-19, to also get that vaccination. Wearing a mask, watching your distance, and washing your hands, it's not the end all be all in keeping us all safe. I think this vaccination is going to do us wonders once it goes online.
And actually there is one more thing I'd like to add, is that in these trials, they're working very hard to increase diversity in the patients that they're testing it on, so that we can prove that it's safe and efficacious to everybody, not just to a certain subset of the population. So they're really working to increase diversity with respect to age, gender, race, to make sure it's generalizable to everybody and not just certain people.
Yeah, thanks, Dr. Cassidy. That was really important. Pfizer, BioNTech, that alliance said that they were going to recruit another large number of patients to enhance the diversity of the initial pool. And I want to make sure everyone knows, most of the vaccines that are in phase 2 and 3 status have shown that they can create an immune response. And that would include the viruses or the vaccines that are being rolled out in China, and there are 3 that are already being distributed, and in Russia. And I do want to say thanks, County Executive Crowley, for your pitch about the flu vaccine. As Dr. Cassidy said, only 40% of the people in Wisconsin actually take the vaccine. I got my shot last Friday.
I'm getting mine with.
Very good. Lots more questions coming in, and in the interest of breaking this up a little bit, Sierra had 3 kind of distinct ones, and so thanks to my team on the back end breaking it up. The first one from Sierra, yesterday the state's percent positive was 20.5% with a 14.9% 7-day average. Why are we seeing this sudden spike? Should we be alarmed in Milwaukee County?
Well, I'll start and say we should be concerned, and we should redouble our efforts to practice the 3 W's that County Executive Crowley mentioned. And yes, it is troubling. Normally, if you are giving enough tests, you should have less than 5% positivity rate. That 20.5% rate yesterday was the highest that we've ever had in Wisconsin. Milwaukee, we struggled for a long time to get down under 10%. And we finally have a large testing capacity and good infrastructure here. And we're down around 5% for almost a month, but it's starting to creep up. Our average now is 8.6%. So yeah, I would say we should be concerned.
I also think since the mask mandate in Milwaukee, and because we suffered a little more initially, that we are a little more diligent with the mask mandate. And I think some of the numbers could reflect the university testing with college students outside of the county.
Sieren's next question was, are we seeing higher positives because only people that are sick are getting tested and not enough asymptomatic people are getting tested?
That's a good question. And I would say that probably we have fewer symptomatic patients because the demographic is younger, and people wearing masks, you might actually reduce the severity of COVID-19 if you get it. But I think what it tells us is there's a large burden of disease out in the community that we're not detecting right now. That's what the positivity rate tells you, is that there are a lot of cases out there that we're simply not testing.
And last one from Sieren, how much do colleges play a role in these high positive numbers?
Dr. Cassidy's the expert there.
Well, I did look at the different universities and to see if they had created dashboards, and they are doing testing. And so what happens is if you find a cluster of positives, then you test everyone around them, right? And so you can find these exposures, through the contact tracing and testing. And I think there's certain many universities are doing more aggressive testing. We do know that the highest rates lately have been in our 18 to 39-year-old age group. There are also tend to be the invincible ones who go to parties and take higher risk and spread it faster. So I don't know that it's necessarily universities as much as it is the age group who happen to go to universities.
Yeah, I think that's fair, Dr. Cassidy. Clearly in Dane County and in La Crosse, the spikes that they're experiencing are mostly due to college age individuals and probably stimulated by the return to campus. And I don't think that we're seeing that quite as much here. I know the neighborhoods around UWM are seeing more cases than they've had before, but the numbers are still pretty small. And looking at around Marquette, I don't think that there's been much of a spike over the last week or two. The County Executive Crowley, you may know better about the link with colleges here in Milwaukee.
I think you both just hit the nail right on the head. It hasn't been linked to the colleges, but it has been linked, seeing a few spikes on the east side, nothing really around Marquette. But I think this really speaks to the fact that we have to really talk to our young people because we've seen a spike between 18 and 29. You are not invincible, and I know that we all love being a superhero, but we're not superheroes. So we have to do everything that we can to mitigate this virus. And it really points to the fact that, if we want to go back to college, if you want to go back to school, if you want to go back to work, we all have to lean on one another and making sure that we reduce the amount of spread.
And another concern is that, the young people who are getting it in a college setting where they're close to each other, then if they go home. So having the plan, what do you do when kids test positive? If you send them back home to the different communities, well, they're bringing the gift of the virus back to the communities, and we don't want it. So, I mean, this is like an important thing to think about, is how this spreads. And, and again, the effect it has not just on the students, but the people who work in the university, the people whose livelihood depends on that job. And if we don't have them, the kids don't have a school to go to.
County Executive Crowley, we have a question for you from Lorraine. Lorraine asks, data has been presented today that African Americans represent the second highest number of cases per 1,000 persons tested, but the highest number of hospitalizations. What role will the county play to ensure that African Americans receive culturally competent treatment and care that is needed?
Well, first and foremost, I have to say that we've been leaning on all 11 Milwaukee area public health officers, as well as our hospitals in the near area. So we have been having a lot of different conversations about how do you treat individuals and communities of color. I would say that we had to learn a lot in the beginning. Before, when the COVID first hit, we said, safer at home. But safer at home for who? We've realized that we've had to change up the messaging across Milwaukee County and figure out more creative ways to go inside of communities of color to really have some hard conversations about what you need to do in order to not only save yourself, but those around you from catching this disease. And we're going to continue to do exactly that. We do a COVID-19 briefing, myself and the mayor, along with some of the public health officials twice a week to talk about what steps that we're taking. But it's extremely important that we continue to rely heavily on the federal government to bring the necessary resources, not only that Milwaukee County needs, but our healthcare professionals and everyone needs to be on the front lines of this pandemic. And it's really about being intentional and reaching those individuals. And so it's not going to be easy when you think about the health disparities that we have seen here in Milwaukee County historically. But we're going to continue to push the envelope, push the needle as much as we can to really focus on equity, racial equity, as well as health equity, to make sure that Black and brown communities doesn't continue to be disproportionately affected by COVID-19.
Very good. Next question is from Brian, and he asks, an article I just read indicates that data from the Southern Hemisphere, which just experienced their winter, reported significantly lower rates of flu due to masking. How much of an impact do you think that could have here?
I think it'll have a very significant impact. If people continue to wear masks, they'll reduce the spread of all respiratory viruses. So this is good news, because I think you're hearing sort of the counter argument is that we're going to have what's called a twindemic with COVID-19 and influenza surging at the same time. And that would overwhelm our health systems. As long as people practice the 3 Ws that County Executive Crowley talked about, we'll be able to battle both COVID-19 and the flu at the same time.
Very good. We had a comment from Savitri. She says, I really appreciate how digestible the data and information is during these MCW webinars. So well done to the whole MCW. Question from Nathan. Greetings. Based on current trends, is there any concern of additional pressure on hospitals and/or a loss of ability to mitigate spread in the next few weeks?
Dr. Raymond?
I'll just start by saying our hospitals are doing fine. We've learned a lot about how to take care of COVID-19. So I don't have those concerns, especially not in the next few weeks, even with the surges that we're having in young patients. You know, if we allow the virus to spread unchecked, out of control, especially with older individuals or people with pre-existing conditions, it'll be a challenge for us. And I did just get off clinical service, and I can tell you that people really do know how to take care of COVID-19 here in the region and to do a really good job. So I want to reassure everybody that the health systems are prepared for whatever comes our way.
And even though that the health systems are prepared, we need to do what we need to do as people to make sure that we don't have to get to that point, which is, again, and then we're going to continue to talk about, at least from my end, is the 3 Ws, which is wear a mask, watch your distance, and wash your hands. We have to do what we need to do as people to lean on one another to stop this spread before we even get to the hospital. So let's lean on one another.
We had two kind of general questions that came in. One, are the slides available? And for those of you still online, the slides are available in the handouts pane of your GoToWebinar control panel. You can download the PDF version of the slides there for follow-up. And then regarding the recording, this is being recorded, and MCW usually puts this on your YouTube channel and other social media for later review. So for those of you wondering about a download and the recording. Tiffany asked, would the vaccine also be recommended for pregnant women?
Really good question. I think the whole issue of who gets the vaccine first and when we're comfortable giving it to people safely is something that we're just going to need to work through over the next few months. And I'm not even sure what I would recommend to a patient who is pregnant right now, because we just don't have any experience with these 3 vaccines that are likely to be on the market here by the end of the year. So stay tuned for more information. You know, I know there's a debate about whether to give the vaccine to kids too, and all the ethical issues involved there.
We have 2 more questions from our audience. So those of you in the audience, get your final questions in here, and then we'll switch to the pre-received questions via email. The next one comes from Kurt. Do you have any concerns regarding the upcoming election in the fall? Did our prior experience with the spring and summer elections prepare us appropriately?
I guess I'll take that one. So I think that it has prepared us appropriately. Milwaukee County, we ordered all the materials that each municipality within Milwaukee County needs in order to pull off a very successful election in November. So we've made sure to provide cleansing wipes, disinfectant wipes. Municipalities are providing pens, so each individual voter has their own pen. And each polling location, they're making sure to not only practice physical distancing, but also has plexiglass between poll workers and voters to make sure that we're keeping everybody safe. So I think that right now, we're doing what we need to do as far as the polls go, but we are still encouraging everyone to apply for their absentee ballot and vote by mail, because again, we don't know what this virus holds, but we're taking every step, every precaution there is to make sure that everyone can vote safely.
Awesome. We had another question come in while we were answering there, County Executive, but these two are related. Heba and Joan, they asked independently about ventilators. Are we now starting to pull people off ventilators, or are we still not to that point? And then Joan also asked, just generically, what is the most recent news on effective ways to treat COVID-19? So maybe any updates on the treatment frontier?
Well, let me just start with the ventilators. We have plenty of ventilators. We have almost 2,000 ventilators that could be used for COVID-19 patients in Wisconsin. So we're fine there. So I wouldn't worry about rationing ventilators. We're just in a different place than we were before. In terms of treatment, really the best treatment right now is dexamethasone. It's an inexpensive old steroid drug that was used for people that had septic shock from other infections for a long time. It seems to really improve the outcomes, not just ICU outcomes, but it reduces death by about 30 to 35%. Remdesivir, which we know was approved a few months ago, is being used, and it has a modest impact, but it's extremely expensive. It's really only being used for the sickest of the sick patients. And we've learned a lot about how to keep people out of ICUs. Simple things like proning, in other words, instead of laying a patient on their back, having them lay on their stomach, really improves their respiratory outcomes. But we sure would like to have more drugs in the armamentarium than we have right now.
And I would like to quickly plug that you can always visit the county website, county.milwaukee.gov. We have a dashboard that tracks everything COVID-related here within Milwaukee County, including the hospitalization rates. And I say that because I have full faith in our healthcare system to do what it needs to do to take care of us. But again, we have to lean on one another to make sure that we are not, contributing to the spread of this virus.
Thanks, County Executive Crowley. And I do want to say, Milwaukee has a fantastic COVID-19 site, one of the best, and people really should be looking there. Would also recommend the Wisconsin Hospital Association site, WHA.org, and the Wisconsin Department of Health Services, really outstanding sites with up-to-date information.
We have about 1 minute left in our schedule, but hopefully you can take these couple of extra questions that have come. It might go a little past the 7 o'clock hour. We had a little flurry there. Jan asked, what protections should someone with brief exposure and masked to a coworker who is tested positive? What protections should someone take if they've had brief exposure to a coworker who's tested positive? Do they need to quarantine themselves, I think is what they're implying there.
Well, the health department's recommendations are that if you're within 6 feet for more than 15 minutes, they consider that a contact and an exposure. So if that's the case, then you should self-isolate and consider getting a COVID test or, quarantining yourself and monitoring for symptoms.
Mary asked, with schools in session and younger population exposure, what can grandparents do to best protect themselves from COVID?
Laura, you want to answer that one? It's a tough one.
It's hard. We love our grandchildren, and but they can be little vectors of transmission. So depending on your health and your age, we have some younger grandparents. Wear a mask around the kids. Try not to physically interact as much.
Very good.
You also said something last week when we had this conversation. You probably want to know what they're doing in their school. If they have good HVAC, in other words, if the air exchanges are filtered or not, if they're keeping kids in cohorts or small bubbles where they're not interacting with lots of other kids, if they've taken the measures to do the 3 Ws that the County Executive Crowley mentioned. Seriously, if they have a good plan, you probably, that'll make you feel a little bit better about interacting with your grandkids.
And we have only one more question that was not addressed by you all. And by the way, thank you all for your answers here. And this will be the final question from the audience, then we'll let everybody go. This was the only question that wasn't addressed so far. Is there a recommended time frame for how long a person should wait between COVID-19 tests if the initial test comes back negative, but symptoms persist or worsen?
Well, first and foremost, consult with your physician or your primary healthcare provider, or if you don't have one, with the public health department. They can give you good guidance, and it may change. But if you think about the biology of the disease, if you have symptoms, you're going to probably have a positive test within a week if it's COVID-19. So if you're going to retest, I would not necessarily retest more than a week after the first test. But again, probably talk to your doctors, the best advice we can give.
Then with that, I'll thank the audience for their awesome questions, and thank you, panel, for all of your great answers. I will wish you a good evening. And Dr. Raymond, I believe you have some final remarks.
I do. I just want to say thanks to everybody for attending, and especially to County Executive Crowley for being such a great leader and really being willing to partner with all the health systems. We really appreciate that. And Dr. Cassidy, thanks so much for joining us. And it looks like we're going to be having more of these, so stay tuned for more announcements. Thanks. Have a good evening.
Thank you.
Thank you.